Hi, and welcome to this week's episode of Ask Dr. Jessica. I'm really thrilled to have one of my favorite pediatric endocrinologists here, Dr. Mitch Geffner. He's a professor at the Keck University. I've known Dr. Geffner a long time, and I'm thrilled to have you here to ask you all the questions we have about pediatric height, growth, puberty, all the good stuff.
Thrilled to be here, Jessica.
So for people that are listening and they don't know what an endocrinologist is, can you describe what a pediatric endocrinologist
Sure.
is and what kind of cases that you see and what particular diseases you guys study?
Sure. Well, the basic premise of pediatric endocrinology is around hormones, which are chemicals, if you will, in the body that regulate many, many systems. And I often answer that question to lay people with the kinds of patients that we take care of are too tall, too short, too big, too thin, too sweet, not sweet enough, too salty, not salty enough, as a simplistic sort of way to capture the kinds of things we do. What does that really mean? Well, we see children relevant to today's discussion who are not growing as they should. In some cases, we see children that are growing too much. We see, unfortunately, a lot of children that are overweight, which often leads toward or may lead toward type 2 diabetes in children. We see thyroid problems, puberty problems, problems with the ovaries and the testicles not working, which of course is partly related to puberty, but other things, adrenal problems. The list is not that long, but it keeps us busy.
So, and with just out of curiosity, within all of those issues, do you have a favorite or a particular area of interest?
I think that is actually why I'm here today, but certainly conditions that affect growth and puberty are big for me. And I'm also involved with some conditions that affect the adrenal gland that are kind of rare.
So then let's start with your favorite topic let's start with one of your favorite areas of interest, growth. Certainly a question I get a lot as a general pediatrician. Can you talk about what's a typical or normal expected what's normal growth that we should expect to see from children?
Sure. Well, that sounds like a simple question, but it's not. So it depends on a few things. It depends on the age of the child. It depends on, to some extent, whether it's a boy or girl. It depends on the health of the child. It depends on if puberty is present. Sort of all of those factors go into it. As a general rule, whether you're a boy or a girl, if your age is between 4 and 10 years, you should grow on average 2 inches per year. That's what I teach to trainees. That's what I teach to parents and families. It almost doesn't matter if you're growing that amount, what part of the chart you're on. So if you're on when I say it doesn't matter, of course it matters to the family, but it doesn't matter in the sense that you're likely to find a medical problem to account for that. If that child is growing on a line that is, or a percentile line that is lower than it should be based on the family height genetics, or if it's just on a line that the parents of the child don't like, whether or not it's correct or not for the family height genetics. But that 2 inches per year between 4 and 10 is a single number. I mean, there's some kids from taller parents will grow more than that. Kids born to shorter parents will grow somewhat less to that, maybe a quarter of an inch on either side, but not dramatically. So that's the sort of bar to compare what an individual child's growth chart looks like. And I don't see patients unless the growth chart arrives before them. Maybe at the same time, but the worst thing for me and the worst thing for the visit is if it comes after, because I will have measurements the day they come, but I won't know how that child got there. And so I need to see the path, the trajectory. A child that is growing at that normal rate will never have anything wrong, almost even no matter what part of the chart they're on. A child who's growing slowly over, let's say, a 6 or 12 month period could have something wrong, and it doesn't matter what that height is. because you could be at the 95th percentile really tall, but if you drop down to the 50th percentile over a year, you're not short by societal standards, but something happened that made you do that. So you could actually have, in that setting, a serious medical problem. And so the rate of growth is the key. And to have a rate or velocity, you have to have at least 2 points over a reasonable period of time, which for me is 6 months. Maybe I'll settle for 4, but 6 is ideal. And so that's sort of the way I look at it. And I also look at this in the context of the parent sites. I've alluded to that. And I will tell you that when the patient is referred to me, the parents' heights come along ahead of time with let's say the information that comes from the doctor's office, maybe 25% of the time. So for the pediatricians who are parents in the audience, please send that information. It's inexpensive. It doesn't hurt. It's not a blood test. And it's so, important. And if you don't send it, we get it, but it makes it just easier before I walk in the room to know what to expect.
So, okay, now this may be a leading question, but why is it so important? Do you find that parents' height makes a big difference when you determine the potential height of their children?
Absolutely. There's two key things that sort of control height. One is genetics. So taller parents will typically have taller children, and smaller parents will typically have smaller children. Less important are the grandparents and the aunts and uncles, but it's really the parents. Now, if the parent is somehow shorter than, let's say, a sibling that parent has of the same sex, and maybe that parent had a medical condition that affected height, the formula doesn't work quite as well. And that gets to the point of the other thing that can alter expected height, and that's a serious or chronic medical illness, let's say severe heart disease, things of that nature. So your genetics, unfortunately, you may not get the full benefit from them if you, as a child, have some serious medical problem that affects your nutrition or your just anything that's important in the world of growth.
A lot of parents will say to me, they'll wonder, they'll say, well, I have a really tall grandparent or a really tall uncle. Does that play much predictive value in height of a child?
Minimally, and I hear that too.
Is there a way that parents can predict the height of their child based on the mother and the father's height?
Right. Well, yes, there's something called the internet, and you can look it up. But there's probably more than one formula. But the formula that we use that works sort of the best is I'll tell it to you. It's going to depend if you're making a prediction for a boy or for a girl, obviously. So if you wanted to know for a male child how tall they're supposed to be using solely the parental heights, which is what we do, you average the father's height as is in inches. With the mother's height, after you adjust her height by 5 inches, that masculinizes her. That would have been the height she would have been had she been a male. So if a mom's 5'2", she becomes 5'7" for this equation. And let's say the dad is 6 feet. So 6 feet average was 5'7" is 5'9.5". And so you have to use that correction factor. Now, nobody, including me, certainly can predict height to a single number. That would be, I wouldn't be on this podcast. I'd be working in Las Vegas at the lounge show, making money. But seriously, so we use a statistical sort of method to broaden that range by plus or minus 2 inches on either side. And that's about 70% accurate. It's still not 100% accurate. For a girl, it's sort of the reverse. You use the mother's height as is because she's a girl, and you feminize the father's height by subtracting 5 inches, because that's what he would have been had he been a female, and then you do the average in plus or minus 2 inches. That's the formula.
And this gives you a rough idea what to expect for your child's future height.
About a 70% roughness. That's pretty good.
That is pretty good. Now, what about, there's a lot of questions I get from parents that they want to know what multivitamin to give their child. They're concerned that their kid's not eating enough. How much do these factors make a difference in determining final height?
So I think the broader question is what is the role of nutrition? in all of this. And clearly, nutrition is important. Uh, and it boils down mostly to calories. The reality is, if a child gains weight reasonably well, that child will grow to the rate that he or she is supposed to. Now, in a third world country where calories and protein intake can be, severely limited, different story. But in the United States, that's less of an issue. But if a child is having, a poor calorie intake for whatever reason, supplementing that is not a bad idea. Whether that's with, prefab sort of high calorie formulas, formula shakes, or going to a store or making your own, shakes with a lot of calories and good nutrition. It probably doesn't matter greatly, whatever is palatable. So that's okay, but that's not going to take a child whose height is at the 5th percentile and bring it up to the 95th percentile. It's not going to happen. Okay, it may help a little bit. Things such as vitamins and like vitamin D in particular, these are all good for your health. I'm all for them as long as too much of them is not taken, because actually people don't sometimes realize that you can get very sick from excess intake of vitamins. Whether any of that is going to cure, if you will, a growth problem, in general, I would say it doesn't.
So if a parent says to me, Dr. Hockman, my child is too short for my liking. I want to make sure they grow to their full potential. I want them to grow more. Is there anything a parent can do for their child, whether it be sleep more, offer certain nutrition or supplements? I just want to hear what your thoughts are. Is there anything at all we can tell parents to do?
Well, as I kind of stated about the nutrition angle, unless somebody is severely undernourished, that's probably going to not greatly affect the height. It may replenish some things that are missing, perhaps, or at low levels, but it's probably not going to have a dramatic effect on height. As to sleep, I get asked that one also. I think we're all brought up where our parents tell us, "Oh, if you'll sleep more, you'll grow more," and that's based on it's based a little bit on the science of growth hormone. The body's growth hormone is produced mostly when we sleep. And so the parent, not in a way, but it assumes that, well, less sleep, less growth hormone, simple. But there's never been a study done that I'm aware of, a research study that has shown a difference in height based on hours of sleep. So one of the other reasons parents want their kids to get more sleep is so they have a little more time without their kids to recover from the day. But that's,
I'm guilty of that.
A whole other thing.
All right. So I think that's good to hear. I think for some parents, maybe it'll relieve the stress that there isn't more for them to do, that they don't have to get their kids Boost or Ensure or get them to bed at 7 o'clock to get them to be an inch or two taller.
That's a good summary of what I was saying.
So is there a time, though, when parents should pay attention if their child is not growing enough, when they should see a pediatric endocrinologist or talk to their pediatrician? What are the warning signs or lack of growth per se? Is it when they're not growing those 2 inches a year? Is there anything else that parents should be paying attention to?
Well, I mean, the cardinal thing that both the parent and the pediatrician or the primary care physician should be looking at is what has happened like over the previous year. Kids come in for physicals, typically once a year, and so there's numbers, and so that should be gauged. I know kids will come in between those annual physicals, but oftentimes height is not part of an acute care visit, so you may not get that information. But if there's a beginning of a trend, but it's a relatively small trend, then maybe the pediatrician should see the patient back in 4 months or 6 months, not wait another year, specifically for the purpose of a height check. But the old sort of standard, if a child's height over a reasonable period of time, say 6 to 12 months, crosses over one of those sort of prefab lines, those percentile lines on there, or certainly if they cross 2, that's immediately that child should be evaluated by an endocrinologist. But I should point out to you, and this probably makes up the bulk of my business, and that is parents still sometimes and frequently want their child's growth fixed. even if it's not broken. And what do I mean by that? I mean, not broken, that meaning there's not an underlying medical condition. They're just small and having a tough time, say at school. Maybe they're getting picked on. Unfortunately, bullying is ever prevalent. Sometimes they have a younger sibling who's past them in height. That actually worries parents. And it's tough on that kid because the younger one sometimes says, I'm taller than you are, whatever. And so the psychosocial ramifications of being small, in my eyes, are large. Maybe not in an insurance company's eyes, but in mine they are. And so I see plenty of patients who are not falling off, but they're just small and smaller than they should be. Now, some of those, when we didn't get into yet to the concept of the bone age, which is, I think we need to get into that, some of those children are just going to be late bloomers. And their final adult height, they'll just get to it after their peers do, their final heights, and they'll turn out just fine. Unfortunately, though, they'll be at a disadvantage throughout their childhood because they'll be small, and that could affect them socially. It could affect them athletically. It's another reason parents come. My child is a great basketball player, but he's too small. I'm sure you see those too.
Would you say that? Would you say that the late bloomer phenomenon is probably the most common reason why kids are shorter than their predicted height from parents, or not necessarily?
At the moment that I see them, yes, that absolutely 100%. Yes. Okay. Probably the most common reason I see a referral though is because the child is short and the parents are short. That's not a late bloomer. That's just what we call genetic short stature or familial short stature. Both of those entities are variations of normal, but sometimes variations of normal from which the child suffers, and secondarily, then the parents feel bad and they want to try to help their child. And I see many more patients with those two situations. I don't even want to call them conditions because they're not conditions, they're just variations of normal, than I do of children with something that's a real disease causing their short stature. Disease is very rare in the growth field. I mean, it definitely happens, and it's going to happen, more in my practice than it will in yours because the patients are funneled to me like that. But still, the majority of the patients I see, they're otherwise healthy. They're just slow growers for either familial reasons or late blooming reasons.
Right, and in my personal life, myself, I'm almost 5'9". My husband is 6'1", and our son is the 15th percentile for height. And so, I monitor that he does grow that appropriate 2 inches every year. And I just sort of, it is what it is. It'll be what it'll be. But I'm curious to see if he'll be a late bloomer.
Well,
maybe at some point I'll do the bone age if you want to.
Yeah.
Or go
Let's
ahead.
talk about that's a great segue. And I'm going to whisper to you, you should get the bone age. You don't have to. So what's a bone age? A bone age is the age of the bones. And how is a bone age determined? It's determined simply from looking at the presence and configuration of growth plates on an x-ray of the left hand. And people always say, the left hand, where does that come from? And so 50 plus years ago, when the concept of bone age was first sort of discovered, the standards were taken using left hands because it was thought that since most people are right-handed, you should use the non-dominant hand. It turns out it doesn't matter, but the book which we use to sort of determine the bone age is a book of left hands. Now, the bone age should normally be the same age as the child. So if you were 5 years old, you should have a 5-year-old looking hand. If you were 10 years old, you should have a 10-year-old looking hand. Now, if perchance, let's say the child is 10, and they're the size of an 8-year-old, they may well have the bone structure, the bone age of an 8-year-old. And so meaning that it's 2 years younger than they actually are. If that's the case, they're going to be 2 years shorter than they should be at that moment, but they should have the ability in the future to grow for 2 extra years after the age when their peers of the same age stop growing to then catch up. So it helps them in the future. If you can see into the future, it's a good thing, and you don't have to do anything about it because it's going to happen by itself. But some people are impatient, or some people want the quick fix, so we have to sort of deal with that as it comes up. Now also, when your bone age is 2 years later than you are, not infrequently, going to the past, you will find that that child's teeth were late. Either eruption of the first baby tooth, instead of being at 6 months, let's say it's at a year, or instead of the loss of the first baby tooth naturally, which typically is around the age of 6, happens at 7 or 8. And so, and then, the parents go, what's going on here? What's taking so long? And the kid says, oh, my friends are getting their money, for losing their teeth, and I'm poor. So, but, and then sometimes parents don't remember if they have a bunch of kids. It's hard to remember these things, but it can be a sort of a early clue that what the future is going to hold in the world of growth. And also, lastly, if your bone age is 2 years younger, let's in that example of 10, it's 8. So let's say when you're, 12, it's going to be 10. And you're not going to start puberty when your friends do either. You're going to start puberty late because the timing of the onset of puberty is much more closely linked to the age of the bones than to the age of the child if the two are significantly different from one another. So that sometimes adds insult to injury because you're going to high school in 9th grade and you're a small boy and all the girls have already had their growth spurts, and we haven't even talked about that yet. But it just sometimes the perception, understandably, of where you fit in, which is often gauged on size, becomes even more awkward when you go to a new school, especially when there's older kids there than the seniors, who are giants, relatively speaking. So this can be hard. We just need to be, sympathetic to it.
I notice the parents that seem the most concerned, I find, not to generalize, but I meet a lot of fathers who are concerned when their sons in particular are shorter. And I think when I ask them more questions, they remember their childhoods when they were shorter, and they worry for their children. They want them to have an easier childhood. So I do find that the late bloomer phenomenon tends to be genetic. Would you agree with that?
About 50% of the time, half.
Interesting.
The other half, it's not, but it'll be possibly passed down to the next generation.
So let's say, for example, my son, if his bone age I find is 2 years behind, is there anything else that I should do, or can we call it a day and say, oh, okay, I know my son's going to be that late bloomer and he'll be delayed a couple of years and eventually he'll grow enough? Or do you think, as an endocrinologist, from your perspective, is there any more testing that should be done?
Not if he's consistently growing at a normal rate at that setting, or that bone age, with that bone age reading. No, that's really just reassurance from me to you. That's a freebie.
Now, that's really great to know, because a lot of parents, will find the bone age is delayed, and there's a question, should we be checking more hormones just to make sure? But good growth.
I totally agree with that. But so that's why you need accurate height measurements over time.
Yes.
That's the guidepost for that. And I should just qualify. We're probably talking about after the age of 2 years, because there's another thing that happens sometimes that confuses the matter. So if we go back to birth for a second, okay, the birth measurements, certainly birth weight doesn't correspond with anything, because if a mother is well nourished, she's going to have a big baby. And so sometimes you see growth deceleration after birth, both in weight and length, because the mother was just too good of a self-feeder, and maybe she put on a little too much weight. And so that makes the baby grow bigger and actually to outdo its genetics in fetal life. And so when the baby comes out, they channel down. We always talk about, growth that sort of channels up, but you can see channeling down of growth. And so in that window, I think unless there's some, other medical aspects to that child's story, you don't want to get too worried about that unless it's like extreme.
No, I love that you bring that up, because this is a frequent story in our office where a baby will be, let's say, 95th percentile for weight, 95th for height. And as they get to be like 9 months a year, they slim down. Their growth they're not at the same percentiles, and parents worry. But it's great to hear you say that this is a normal phenomenon.
Well, it certainly can be. I mean, the trick of all of this is always to know when something is most likely to be normal, when it might not be. And that just requires a lot of savvy and clinical experience, and if the pediatrician needs a little, extra support, that's why I exist.
Yes, absolutely. Absolutely. That was great. All right. Well, thank you. Thank you. Thank you. I really genuinely appreciate it. Thank you. Thank you.